All right, everybody, you are listening or watching Wake Up Call, the podcast. I'm your host, Christina Previtt, and we are here today with another edition of the #FemDoctor series. And my guest today is Serena H. Chen MD. She is a fertility specialist in New Jersey. Welcome, Dr. Chen.
Thanks for having me.
Thank you for saying yes. And I will warn people that you have a very colorful personality. Not warn. It's not a warning. It's more like, hey, not a stuffy doctor here at all. So thank you for that. So I wanted to start out with just kind of getting to know you a little bit from your educational background. Did you know that you always wanted to be a physician?
I actually, I'm the firstborn child of immigrant Asian parents who themselves are both physicians. So that means that from before the time I was born, I was supposed to go to Harvard Medical School and become, like a neuro-ophthalmologist, something that would be extremely hard to get into and extremely intellectual and make an extreme amount of money without working too hard. All of this was decided ahead of time. Supposed to go to Harvard undergrad, Harvard Medical School, do a residency at Harvard, because in that generation, Asian professionals coming over to the United States, that's the ultimate in success, having your children go through that. So
no pressure.
No pressure. So that's how we started. And so I kind of rebelled against that a little bit. I mean, I was still a good kid. I took the piano lessons and the violin lessons and the flute lessons, and I got all straight A's and all of that. But when I went to college, which was Brown, when I decided I wanted to apply to Brown, the quote from my dad was, "Brown, that's a color. That's not a school." And I'm like, so that, and luckily that year, Brown was on the cover of Time magazine as one of the hardest schools in the country to get into. And I explained that it's in the Ivy League, just like Harvard. So they reluctantly agreed to let me go to Brown.
Wow. Only Brown.
Yeah. So I went there and I was determined to be a computer programmer, because I was like, computers are the future. They're going to run the world. And if you know computers, you can run the world. So that's what I went there. That was my plan. And I'm definitely not going to be a doctor, because my parents really want me to be a doctor, and I really don't want to do that. So, but ultimately I was terrible at computer programming. So.
Yeah, that's not my gig either. I would never have thought of that.
So it just wasn't a good fit for me. And it turned out that I gravitated a lot towards, like, my favorite classes turned out to be a lot of the biological classes. Like I had and I ended up majoring in biology and anthropology, a typical Brown type major, and really, really loving some of my biology, anthropology professors. And so then medical school made more sense by the time I got to junior year. And
then were you like, darn, I'm going to make my parents happy.
Yes.
I'm not going to be the rebel that I thought I was going to be.
Yeah, by that time they had relaxed a little bit. So, and they realized, like, my grades really were not the best at Brown, because, college is like, I needed to, like, learn about the real world a little bit. So I did get into Duke, and was very excited about that. And my dad was actually super excited, because the tuition was so much less than Brown. So he was really happy. And then my mom went to a cocktail party with a bunch of her Asian friends, and she came home. She was really, really upset, because she had told one of her friends that, I got into Duke Medical School, and the friend was like, "Oh, so sorry, not Harvard." And my mom was like, "That Mrs. Lee, she a bitch," So
did you apply to Harvard?
What?
Did you apply to Harvard?
No, I did not have the grades. I did not, I did not have the grades. I did not have the grades. So I did not even apply there. And Duke was definitely the best school I got into. So, I was really grateful to get into Duke. And actually that turned out to be a really wonderful experience to go down south as an Asian female, because that school at the time was probably 70% Southern and 70% male, and very white male dominated. So it was very interesting experience compared to the diversity at Brown. And I learned a lot, and I had a wonderful time. So
Wow. So when did you decide that you wanted to specialize in fertility, or did that just sort of happen?
So I was interested in everything, and when I got to Duke, a lot of it turned out to be about the people. Like the people that I connected with the most was the OBGYN department. Like I honestly didn't really like the idea of OBGYN because the lifestyle seemed a little tough, on the weekends and the night call and things like that. But I had such a great experience on the rotation and really connected with the people that ultimately it seemed like the right fit. And I did not really think about doing much more than OBGYN until later. Once I became OBGYN, I was interested again in everything. I liked cancer, so GYN oncology. I really liked high risk OB. I liked general GYN, and IVF was actually still very new. Like when I went to Hopkins for residency, and at the time our IVF lab was essentially in an incubator that we kept, a baby incubator that we kept in a broom closet. So it was very, very, very beginning. And at that time that the Senator Wyden passed the Wyden law, because the CDC was very, very concerned about the fact that people all over the country were opening these IVF labs and charging a lot of money, and the pregnancy rates were close to zero in a lot of these labs. So the government felt like, there needs to be some oversight of these clinics, because this is just not right, because the technology was very, very new then. So that was in the 80s, and a lot of people were like, oh, that's really experimental. I will never do IVF. And that's part of what I really liked about it, is that it was so new, and you could see there's so much potential. I couldn't have imagined what it would be like today, because the field is it's just exploding on all different levels, pregnancy rates, technology. It's amazing what's happening in our field. But at the time, you could tell that there was a lot of excitement and a lot of potential. I mean, growing a baby in a test tube sounds crazy. So I decided, well, that's really fascinating. That's what I want to do.
So back then, if you couldn't have kids, or maybe right before IVF, if you couldn't have children, there really wasn't much you could do. You could adopt. And that was kind of it.
Yes, there was not a lot we could do. We did a ton of surgery, because surgery would raise your pregnancy rate maybe from 1% to 2%, which is an improvement, but really not much. So we had very few tools. Like we had a few diagnostic tools, but very little treatment tools. And yes, a lot of people just tried the same treatments over and over and over again. We did a lot of surgery. We did a little bit of hormones, and a lot of people just did not succeed and did end up adopting.
What was the surgery? What would that do?
So we would try to repair tubes. We would try to remove endometriosis for infertility patients. Infertility, the prevalence of endometriosis may be like 10% in the general population, but the prevalence in the infertility population is like well over 50%.
Oh.
All ranges of endometriosis, from stage 1 and stage 2, which are really almost impossible to diagnose without a laparoscopy, to really severe endometriosis that makes these big cysts and can block tubes. But every stage of endometriosis does cause a significant decline in fertility. And we had just, our only tool at the time was really surgery.
So do you know, is there a higher incidence of endometriosis than there used to be?
You know, that's a good
Just know.
question. I don't think we have good data because we no longer do laparoscopy. So a huge portion of patients that we call unexplained infertility probably have stage 1 or stage 2 endometriosis. So we don't know that. Now, having said that, a lot of people feel that environmental exposures that, you know, of modern life have, and delayed childbearing both lead to higher rates of endometriosis. So we want people to avoid things like endocrine disruptors, that like parabens and phthalates in your products and your cosmetics, avoid microwaving and plastic. We feel like those things can be associated with endometriosis, with birth defects, possibly with hormonally responsive cancers like prostate and breast. So, and those are things that have been around for a while and only now are starting to be regulated in the United States, and only now are consumers starting to be more aware of those issues. And then the delayed childbearing is definitely becoming more and more prevalent every single day, which, you know, leads to higher rates of endometriosis, because pregnancy can be protective. Now, having said that, you know, birth control pills are really protective against endometriosis. So that's definitely one thing that can actually help preserve your fertility in many ways, and lower your risk for ovarian cancer and cancer of the lining of the uterus. So that's one of the nice things that we see with birth control pills, which is ironic because a lot of people think birth control pills lower your fertility, but in some ways, especially for people who are high risk, it can really be helpful.
Well, I think a lot of people think that it causes cancer too. That's what I've
Yeah,
heard.
people worry about that. Exactly. And actually the cancer reduction benefit of birth control pills really outweighs any possible increased risk of breast cancer. There are some studies that show possibly a mild increase in early stage breast cancers, but a lot of studies say they don't really see an increase. So that jury is still out.
That's interesting. Yeah, it depends what magazine I'm reading or what news program I'm watching. So I guess that your answer would be the same. You know, do we have more infertile people, couples, or is it just that people are having children later and maybe they're not as fertile, or we're just more attuned to these kinds of things because we have the technology?
I think all of those things come into play. I think all of those things definitely come into play. And but you know, we are getting healthier and healthier. The hard part is we're doing better and better with our lifestyle, which is anti-aging, which I think is part of why people want to delay childbearing, because, you know, it totally makes sense. You know, you're working on your career, you feel perfectly healthy. You know, why do you need to get pregnant? I mean, the old days, we used to like just get pregnant, I don't know, at age 16, have 20 kids by 30, and then drop dead of exhaustion by 35, you know, right? So now the average age expectancy is more like 85, right? You know, for in the United States. So it's really incredible what's been going on, and that's why we're seeing IVF technology being used for egg freezing now, which is super exciting.
Yes, I saw something about that on your Instagram page, and that was one of the things I wanted to ask you. But let's back up before that a little bit. What is considered a geriatric pregnancy?
Okay, so I would say that we should get rid of that term. I don't know who came up with that term.
Yeah, it's not very flattering.
I think, honestly, nothing against guys, but I think that must have been made up by some guy. Because
Probably.
geriatric pregnancy means just over 35, supposedly. That's the common use of it, which is insane because 35-year-olds are young. But that is the point. This is a historical designation, because at age 35, the risk of having a child with a chromosomal abnormality reaches about 1 in 300, and that's the risk of losing a normal pregnancy with an amniocentesis, typically. So that's where the risk-benefit ratio lines cross. And that's why at age 35, we always used to do amniocentesis at age 35, because the risk of, finding a real abnormality definitely, was there, and it justified taking that small risk of putting a needle, into the pregnant belly and pulling out fluid to check the genetics. So it's an arbitrary decision and line, but that led people to start saying, well, this is 35 is advanced maternal age, and then people started using the word geriatric, which I think is even worse than advanced maternal age. So it would be nice to come up with another term, but it's a historical term, and I'm not sure that it's necessarily clinically relevant anymore, but people still use it because, now with a lot of non-invasive genetic technology, people are no longer just routinely doing amniocentesis at 35. That just doesn't make sense for us anymore.
Yeah. Well, historically, I mean, people did have kids a lot younger. If my mom had me, well, I think even in her generation, maybe it was a bit young. I'm 45, and she had me, I think, when she was 21 or 22. Yep. And, according to her, that's what everybody was doing in that generation. And certainly now it's much more common to see women well into their 30s and even 40s. I think I've actually heard of some people in their 50s having babies.
Yeah.
So is it just, maybe it's not really what our bodies were designed to do? And I'd love to hear your opinion about that, but maybe it's just sort of what we've grown accustomed to.
It's what we've grown accustomed to, and obviously there's societal pressures. From medical perspective, we definitely start to see higher rates of things like diabetes, high blood pressure, preeclampsia over the age of 40, 42. Although I'm not sure that's really controlled for optimizing your general health, because I do think we have such a high prevalence of obesity and poor lifestyle. It's hard to separate age from lifestyle. And if you really optimized your lifestyle, would you still see those same effects? Definitely with regard to fertility, that's the one thing that we don't seem to be able to change very much with healthy behaviors. So we have like a little clock in the ovary, and it seems to be programmed to just degenerate over time, so that as you get older, you just make a lot more eggs with extra or missing chromosomes. So that seems to be really programmed in there. So that's definitely, we can't seem to change that, even if we're, healthy, non-smoking, vegetarian, exercisers.
Yeah.
So, but the other stuff, a lot of the other stuff, like your ability to carry a pregnancy and be healthy, I think can be somewhat modified by healthy behavior.
So would you say, and I know I'm asking you to generalize, but is it, healthier for a woman who's 40, but, a vegan exerciser who never smoked and, is lean and all of that? Is it safer for her to have a child than it would be for someone maybe who's 32, who's obese and has diabetes and has high blood pressure?
It could be, but that 40-year-old will have a much higher risk of conceiving a child with Down syndrome or having a miscarriage in the first trimester, because miscarriages in the first trimester are genetically based, not really general health based.
Is that nature's way of rejecting the fetus because there's something wrong with it? I've heard that before. It is.
And it happens in like at least 1 out of every 4 pregnancies. So it seems to be fairly routine for nature, although people process it like a death. So it's really it's a little bit harsh, I think.
Yes. Not the right thing to say to someone who has had a miscarriage.
Yeah.
But even though it seems to be that that's the case. So take me through this. I'm 45. I come to your office and I say, Serena, Dr. Chen, I've been having lots of sex trying to get pregnant and it's not happening. What do we do now?
So we do a very thorough evaluation, heart, lungs, breast exam, a vaginal ultrasound, a lot of blood work, and we check your partner's sperm and his blood work. We try to get you to optimize your health, and maybe we try using your own eggs. But at 45, a lot of people's eggs don't work, and then we might think about egg donation.
They don't work. But we were born with all of our eggs, right? Women are born with their eggs.
Yeah, you're born with all of your eggs, and you run out around 51 on the average. That's when menopause occurs. But sometime around 42, 43, the numbers game really stops working, so that even if we like do IVF and we get a lot of eggs, what we're seeing is like a 95, 99% abnormality rate genetically. So it can be really tough. But the technology is getting a little bit better. And I think that now that the technology is improved and we can do genetic testing, there are some people in this age range that can produce a lot of eggs and might be able to get a normal embryo and have a pregnancy. But the pregnancy rates tend to be really, really low still without egg donation. So, but it's really common. I see a lot of people in their mid-40s who really want to go through fertility treatment, really don't want to think about donor egg, and we give it a try, but it's definitely hard. That's one of our biggest challenges.
So the problem is with the egg itself. It's not with the person who would be
right.
carrying
Exactly.
it.
It's not with the person. Exactly. So all we need is a healthy egg, and we get a healthy egg from whatever source, and we can make a healthy embryo. Then it's really, the uterus doesn't seem to age the same way the eggs do. So the uterus seems to be able to carry a pregnancy much longer, to a much more advanced age for a lot of people than the egg. Now, having said that, a lot of people as they get older will have more issues like fibroids and things like that, which sometimes can make the uterus less hospitable. But the problem with age lies in the egg itself.
Oh, that's interesting.
Which
I remember,
which is why there's such a big focus now on the egg freezing.
yes, I was just going there. So I remember when I was 27, I was sitting at the kitchen table with my grandmother, and I don't know how this came up, but she goes, your eggs are old. And I'm like,
Wow.
thanks, Grandma. So I don't know. Were they old at 27? When do they get old? Whatever
So
that
that's
means.
interesting. 27 is supposedly when we start seeing some decline, significant decline in fertility. Although what I tell most people that are thinking about their eggs is, get a checkup, make sure there's no issues, because like what if, God forbid, you're walking around with a big hunk of endometriosis in your 20s, then your ovaries are going to age prematurely. But most people, if everything checks out, everything looks good, then, between 30 and 35, if you're not ready to have a baby yet, think about, well, maybe it's time to get some information about egg freezing.
So do you think there's a point at which it just doesn't make sense to freeze your eggs, like if you're 35 or over?
I freeze a lot of eggs over 35 because a lot of people still have plenty of good eggs to freeze. So I think it's very, I don't like to set arbitrary, lines.
Mhm.
I like people to know the numbers, like to know the logistics and the numbers, the risks, the benefits, and, and the money, because that's often, egg freezing is often not covered, and which is which should not be, really it should be covered, because freezing eggs, especially in a society where the birth rate is so low and everybody is trying to delay childbearing because a lot of people are, finding the right partner or getting an education or working on their career, it's really a societal benefit to be able to freeze eggs, because if you can preserve somebody's fertility and lower the risk for infertility and miscarriage and birth defects, that's a benefit to all of society. But the burden right now, the burden of egg freezing is upon the individual woman's shoulders, which to me doesn't seem quite fair. It does seem like it's something that we should all be supportive of.
Yeah. Well, I'm kind of wondering, it seems we can't do anything about this, although you never know. Why are women born with all of their eggs? Why can't they just produce more eggs like men are always producing new sperm?
That's a good question. I think it's because eggs do so much more work than sperm. So
that's not surprising.
It's not surprising at all. So you look at eggs under the microscope, eggs are like Jupiter, and sperm are like little ants, because sperm are super small, one of the smallest cells in the body. Eggs are one of the largest cells in the body, and that's because sperm are very lean and mean. It's just DNA and then like a tail to get the DNA to where it's going, and that's all they do. They do nothing else. They just deliver the DNA. And meanwhile, the egg has a huge amount of stuff, because the egg has all the messenger RNA, all the proteins, all the ribosomes, all the organelles that the little embryo needs for the first 3 days of life, because the sperm genome takes 3 days just to get going with what it's supposed to be doing, like, making proteins and things like that, like contributing. So the sperm doesn't contribute anything for the first 3 days of life, and the egg does all this work. And so biologically, I think that's a much higher cost, and maybe that's why this happened. I don't really know. It's just my theory.
Yeah, it's very interesting. I mean, I don't know that we'll ever be able to do anything about that, but it's interesting to think about the new technology. I'm sure that when IVF first came out and they were calling those test tube babies, I don't hear that expression as much anymore, but there was a lot of controversy in the news about that, about whether it was moral and, what kind of society are we living in where people can create a baby outside of the body and all of that. I think we've come an awfully long way since then.
Yes.
Maybe you could talk a little bit more about the technology that we have other than just IVF, because I know and maybe you can even clarify exactly what IVF is.
So IVF stands for in vitro fertilization, which just means that fertilization takes place outside the body in a dish in the laboratory, whereas normally fertilization takes place in the fallopian tubes. So we really don't have a ton of a huge range of treatments. We have like fertility pills, fertility shots, intrauterine insemination, and those are non-IVF treatments plus surgery, and then doing things like correcting abnormalities, like checking your thyroid function, doing all those kinds of things, like addressing medical issues. IVF, on the other hand, even though it was designed to bring the sperm and egg together in people who have blocked tubes where, the sperm and egg just physically couldn't get together, IVF these days has advanced so much that it ultimately can treat basically every kind of infertility. And it can treat also, and it can also, help people who don't have infertility but need help conceiving, like lesbian couples, gay couples, transgender people. And actually this idea of making all your eggs for your whole lifetime, when you're a fetus, and running out of eggs will be done soon. Like, we might not be able to take advantage of it, but I think maybe the next generation actually could, because stem cell technology is advancing quickly, and it is possible relatively soon that we will be able to scrape some skin cells into an envelope, send them to a lab and have the lab manufacture eggs or sperm for us.
That's crazy.
Crazy. Yeah.
That does
People are
sound.
working on that as we speak. So we may be able to solve this, the issue of menopause and a lot of fertility related issues or age related infertility issues possibly in the next generation.
So then the question that always comes up when you have some really new technology like that seems so radical is, okay, we can do that, but should we do that?
Christina, that's like, we could talk for hours about this. This is huge. But, right now, okay, that's like the next generation. Right now, if you really, really wanted to, you could, go through IVF, make a lot of embryos, and, that's not really commercially available, but the knowledge base, or at least not really in the United States, but the knowledge to be able to take those embryos and do things like check for projected height, projected intelligence, that technology actually is kind of here now. It's not really practical right now because if most people only make a couple normal embryos, so like out of a dozen eggs, it actually turns out we're very inefficient with conventional IVF. You make a dozen eggs, which is like a year's worth of eggs. Really only one or two of those eggs is going to make an embryo that can make a baby. We're just really inefficient that way. A lot of eggs and sperm are just not good enough to make a healthy baby. But if we combine this ability to do testing with the ability to make more eggs or more embryos, we're looking at a very huge power to basically, do genetic determination or, a quote unquote designer babies.
Yes. Yeah, I've heard that expression. It just seems so astounding to me that all these people are around in the world and there's so many pregnant women when it's really a miracle to get pregnant. There's so many things that have to go right.
It's true. It's true. It still amazes me every day. I do this all the time, but it does still amaze me every day. So, but that's part of what's so great about this field is like there is a lot of cool technology, and it's advancing all the time. Some of it's a little bit scary because we all have to think about, like, if we do a lot of genetic selection, are we going to get to a point where insurance companies are going to say, you didn't have to have that child with that genetic disease. You could have avoided that. And we're not sure we want to pay for that. Like there's a lot of crazy things that can come out of this technology. So I do think, everybody, even people who are not doctors, people who are not scientists, like everybody needs to be more aware of this technology so that we can kind of see, like, as a human race, like where do we want to go? How are we going to use this? It really is like, it really does remind you of, the 1920s book, Aldous Huxley, Brave New World, like where they were designing, okay, I don't even remember the categories, but there were categories of people who could only do this level job and categories, and they were just like genetically programmed that way.
Yeah, I'm sure there's movies about it too.
Is it Galactica? No, Gattaca. I think it's Gattaca that where that's kind of the principle in that movie. That was like, maybe Tom Cruise was in it. It was some popular movie like a few years ago where they were like, yeah, you can only do this, and then the handsome lead actor decided he was going to do something else. Yeah, something like that.
Do you ever foresee, is there any, like even a morsel of evidence that we could ever reproduce without either having a man or a woman?
Yeah, the stem cell, well, right now we do that with, a gay couple will use donor eggs. So they could just order some donor eggs from an egg bank or use a carrier. But for the future, this whole thing, the stem cell technology, like theoretically, you could take the stem cells and whether you're a man or a woman, you could make either eggs or sperm.
So, okay, so if you were writing a science fiction book, you could actually, have something plausible in your plot where, some evildoer gets rid of men. They're gone. We don't want them here anymore. They're useless. And there's only women left. I'm not suggesting that this is a good idea, but just for purposes of this conversation, because I kind of like men. And is that something that you could actually come up with something plausible where that could happen?
Yeah, so this would be the handman's tale as opposed to the handmaiden's tale, right?
Yes. Somebody should write that.
Yeah, and then we could all dress up in interesting outfits and become an HBO series.
Yes, I'm going to write to Margaret Atwood and I'm going to hook you guys up. Maybe you could work together.
We go.
That's crazy. That's really
Isn't that
crazy to even think about.
It is crazy to think about, but we have to think about, there's I don't know if they're still advertising. I haven't looked recently, but there's some practice in New York that is claiming that they can choose your baby's eye color.
I've heard stuff like this.
Yeah, which is and a lot of couples, this is mostly the infertility population. It's actually not so common with people who are not infertile, but a lot of infertile couples that have to do IVF anyway, if they have more than one embryo, will often say, can I put in the XX embryo instead of the XY embryo? Can I do the XY embryo first? Like they, essentially do sex selection.
Yeah. Yeah. I mean, I don't know that that's so radical. I remember when I first heard that much younger, and I remember this news program about, was it moral for us to be able to pick the sex now, and where are we going next? And this was a long time ago, but I don't know if that doesn't seem so weird anymore.
It doesn't seem so weird in the United States, but when you look at like when the WHO actually has come out against sex selection because they look at it in like the East Asian countries where there's actually, it's not just sex, it's not like family balancing where, in the United States, everybody wants one boy, one girl, a 2-car garage and a dog, right?
Yeah.
But in India and China, they have actually done sex selection through, abortions and female infanticide, or even just, something a little more subtle, like just not taking the girl child to the doctor as often as you take the male child to the doctor. So they've actually changed their sex ratios in those populations, creating lots of societal, social, psychological, and economic issues for both those countries, including a dramatically increased risk for violence against women with a changed sex ratio. So that can be the dark side of sex selection, which we really don't see here in the United States as much, but that's one of the concerns. So there's all this stuff where it's like we have this amazing technology and we can maybe prevent disease and heal people and prevent suffering, but we always have to think about like the possible other side too.
Yes, there's always going to be a dark side, right? There's always going to be somebody that wants to use it for something nefarious.
Yeah.
So maybe you could walk me through a little bit in a little more detail what happens with the whole fertility treatment. So let's say I go in. How do you get my eggs? Do you have to pump me up with hormones and retrieve them?
Usually we pump you up with hormones, but the hormones, everybody thinks, oh my God, I'm going to turn into a raving mad dog, but you really don't. So again, it comes back to drinking plenty of water, having a good diet, getting a good night's sleep, and kind of clearing your calendar a little bit so you're not super stressed out. If you do those things, my patients are usually always tolerate it really well, because if you think about the fertility drugs are really nothing, most of the time they're nothing crazy. They're just the same hormones that your body makes. We're just giving you a little extra. So instead of, recruiting one egg to maturity. We're recruiting half a dozen or a dozen eggs to maturity. So it's actually not, it's not any weird chemotherapy. It's really just the hormones your body makes, and getting plenty of rest and taking care of yourself usually means you have very few side effects. So most people feel a little tired, which is understandable because you're making extra eggs. And, and that just means you need to rest more. And then some people feel a little bloated. And then after the retrieval, a lot of people get a little constipated, but it's usually nothing severe.
So how do you get the eggs out? I imagine a giant needle.
So it's actually not a giant needle. So the needle's very long because it has to go from the outside of the body all the way to the top of the vagina. So it's long, but the size of the needle is about the same size as a blood drawing needle. So it's nothing crazy. And we attach it to a transvaginal ultrasound probe. And if anybody's had a transvaginal ultrasound, it's done because if we put the probe in the vagina, it's a great way to get a very close-up view of the ovaries. So basically we're just putting a needle through the top, just the top part of the vagina, and it goes right into the ovary. So it's essentially like just a needle stick into the right ovary, a needle stick into the left ovary. You are totally asleep. So I like people to be totally asleep. Some people do it like kind of where people are half awake, but most people in the United States are put totally to sleep. And it literally takes 10 minutes. It's
Probably
like
because we're wimps.
5 minutes for the right. Well, the ovaries are big. We don't want you to move, that kind of thing. It's just much easier. So 5 minutes for ovary, and then you wake up, and it's actually not such a big deal.
So ideally, how many eggs do you want to get?
We'd like to get a dozen eggs per retrieval, but some people only get one egg and some people get 100 eggs. Everybody's a little bit different. And ultimately, the number of eggs you need to make a baby differs a lot depending upon your age. Like women in their 40s, some people say, well, you need a lot of eggs in your 40s to get a baby. But if you're in your 20s, you maybe don't only need a few eggs to get to the baby.
So let me understand how is it that there's not just this, huge amount of eggs in the ovary just sitting there waiting to be plucked?
There's supposedly, if you have a healthy person with normal ovarian reserve, you're right, there should be a lot of eggs in there, but the drugs can only touch a certain number. So like a lot of the eggs are in this quiescent phase where they can't actually even respond to the drugs. And this is why IVF doesn't put you through menopause earlier, because everybody loses about 1,000 eggs a month anyway. And all we're doing is rescuing a few of those with the egg retrieval. So we're not making you go through your eggs faster by doing IVF or doing egg freezing. But we can't not all the eggs will respond.
So when you say lose eggs, are they dying? What's happening to them?
It's programmed cell death. It's something called apoptosis, and we're not sure exactly why it happens. But
this is really educational for me, because despite my education and having read different fertility books just out of curiosity, I always thought that every month there's one little egg, that's in the follicle, and it sort of pops. Like, that's how I imagine it happens. And then it travels through the fallopian tube and doesn't get fertilized, and out it goes. I didn't realize that all these other eggs that are in the ovary aren't just hanging out waiting.
They all start growing, and then one of them takes the lead and is ovulated, and the others that don't ovulate just kind of regress and die. And when we give the drugs, we kind of get more of them to develop. But even though a lot are tagged and you lose a lot all the time, the drugs can only rescue so many eggs.
That's really interesting. Thank you for clearing that up for me all these years. I've been wrong about I thought it was a much cleaner transaction.
You're not alone. A lot of people think that. So
Yeah, that's really fascinating. So you get the eggs, you get however many you get. So at that point you're just trying to get eggs. You don't know that they're actually healthy, viable eggs until you
Right,
inspect them later.
right. And
Okay.
typically we expect um, maybe one out of half a dozen or a dozen eggs hopefully will be healthy enough to make a normal embryo, which usually has about a 60% live birth rate. Now, so that's just like on average. But if you're older, the chances are lower. If you're younger, the chances are better. Everybody's a little bit different.
So if you don't get enough eggs or maybe you don't even get any, do you go back in again?
A lot of times we do. We'll like adjust the medication, see if we can improve the response. Um, there's a lot of data that trying IVF multiple times does improve your pregnancy rate. It doesn't make you more fertile. It just means like every time you try, you're just giving yourself another chance. And so what we see is in the United States is that it's hard that because of insurance and also because just like going through fertility treatment is emotionally really draining and logistically hard to do, that it just takes up a lot of time, that we actually the dropout rate, because people just get discouraged or they just get tired, is actually the
Mhm.
number one cause for failure of IVF in this country, because a lot of people need multiple cycles to get to the baby. That's just the nature of Mother Nature. She's like super inefficient.
It's also expensive, isn't it?
It is expensive, and but insurance is getting better and better. Like in New Jersey, we do have a lot of people covered because of the mandate and because a lot of tech companies and Fortune 500 companies are realizing that recruiting talented people means having really good benefits, and people actually look for good reproductive and family benefits. So people are offering those more and more, which is nice.
Yeah, I've heard of some friends and people that I know that had insurance that covered it and others didn't.
Yeah, it's still tough across the country. I think the number, if you look at the whole country, not all of us are as lucky as we are in New Jersey. So 85% of people actually don't have any IVF coverage.
Yeah.
So that's
Mm.
definitely a tough part. But when you look at the data, the insurance is usually not the biggest barrier. The biggest barrier is often loss of hope.
Yeah, that makes sense. And I'm sure that you've heard this. I know people who went through this whole process numerous times. It was really hard on them. They didn't conceive. And then a couple of years later, they get pregnant,
Yes,
not even trying.
yes. And that's because most of the people we treat are not truly sterile. They're just less fertile than normal. And so they can get pregnant on their own. And sometimes IVF helps, but sometimes, you know, you'll just get pregnant on your own. So IVF is like for somebody who has open tubes and a regular cycle and their sperm, every time you try IVF, there's maybe in our lab like a 60% take-home baby rate, but there's 1 or 2% chance of conceiving on their own each month actually adds up to 30% chance of conceiving over 2 years. So, and that's not insignificant. So a lot of times the reason to do IVF is because like the longer you go, the more depressed you get, because you're not conceiving, and also because you're getting older, and we worry about losing, the opportunity of time.
Yeah.
Um, but most people that are going through IVF or fertility treatment do have the ability to conceive on their own. So it's not that we're treating people who have a 0% chance.
Oh, they just want to move things along with
Exactly.
science. So
Exactly.
I think I know the answer to this based upon what you've said. And this might be a really dumb question, but could you just take the ovary out and just crack it open and take the eggs out?
There are people that do that, and we do that for cancer patients, like pediatric cancer patients where it's really tough to stimulate their eggs, or it's like an emergency and we can't do that. That's really technically much harder to do because it's not so easy to freeze the eggs, and then it's really hard when they're still in the ovary to get them out because you have to get them to maturity. So when frozen eggs are freezing eggs through IVF has just a very high pregnancy rate, and it's just like much easier to do, whereas the number of and there's thousands and thousands of babies now from frozen egg IVF, but frozen ovary IVF, there's maybe like a dozen babies in the whole world that have been born from that, because once you take the ovary out then and you want to use the eggs, you have to figure out how are you going to get them to be mature. So it's just technically much more difficult. They're getting better at it all the time, but technically it's just much more difficult.
Let's get to the men. So if their sperm isn't adequate, is there some way to fix that or not?
You know, basically we solved like 99.9% of cases of male factor infertility in 1996 when ICSI, intracytoplasmic sperm injection, was invented. So somebody accidentally was working with an egg and a sperm and ended up jabbing a needle with a sperm into the egg, and it fertilized. And that discovery, injecting a single sperm into the egg and assisting fertilization, has now solved like almost all cases of male factor infertility. So what are male factor infertility? Our approach is, number one, optimize health, because a lot of people can improve their sperm and their fertility by, you know, losing some weight, drinking less alcohol, sleeping better, eating more vegetables, drinking, you know, like getting some exercise, and avoiding things like taking testosterone. Testosterone actually is like a male contraceptive pill. It'll just kill your sperm. And a lot of doctors don't know that. A lot of people are giving out testosterone and not really telling people like this could knock out your sperm for good. Most people, it only knocks out your sperm for a few months, but some people actually get so much destruction of their testes from testosterone that they become truly infertile, truly azoospermic, no sperm at all. So so you can often improve male fertility with just being super healthy. The other little tidbit that a lot of people don't seem to know is blood pressure medicines, calcium channel blockers, which are one of the most commonly prescribed types of blood pressure medicines, actually prevent the sperm from fertilizing the egg, because the sperm have all these little calcium channels on their little heads, and that's how they stick to the egg. And if you put a calcium channel blocker, it's like they have this little helmet. They just, you know, boom, fall right off. So
wow.
Most people who are prescribing these calcium channel blockers, internists, actually they're not really aware of that, because calcium channel blockers are super popular because they work great for high blood pressure, and you know they're well tolerated, so they're really common. So those two things, people should avoid calcium channel blockers, which are a common type of blood pressure medicine, and testosterone, and you try to be as healthy as you can be. But you know, if you're having problems getting pregnant, mild male infertility we can solve with, you know, just getting healthier and maybe artificial insemination. And severe, you know, IVF works really, really well. It's just astounding.
Yeah. It sounds like it's way more complicated than I even realized, but interesting. It's really interesting.
Super interesting. And guys over 40, maybe think about freezing your sperm too, or try to freeze your sperm before you turn 40, because over 40 seems to be associated with higher rates of autism and schizophrenia.
Oh, wow. That's interesting too.
Yeah. Yeah.
Thank you so much, Dr. Chen, for all of this. I feel like I could easily just go on.
We could talk forever. right?
Yes, we could. I think I did tell you that I was going to ask you if there's any books that have had an impact on you in your life.
Okay, so I really want everybody to read Sean Acor. Let me just make sure I spell his name correctly. He's a professor at Harvard, and he's it's SeanAchor. And the two books that I love of his are The Happiness Advantage and Big Potential. And it's just how, you know, that he just flips the script. Like, he basically discovered that the key to happiness and success is often backwards in the United States, that we think we're going to be happy once we're successful.
Yeah.
And in reality, and there's actually, he goes through in a really easy to read, very accessible way, like not in like a boring way at all. He's a very engaging writer, and you can go through it. It can easily be an easy beach read, where the truth is, it's the happiness that leads to the success, as opposed to the success leading to the happiness. And flipping that script in our minds is just can be transformative. So I just love how he writes and how he thinks, and the fact that it's all backed up by a lot of data, and I think it can really, on a practical level, really help people be more successful in life.
Well, thank you. That helped me, because I know I fall into that trap. Like, once I have this or once I do that, like everything's going to be different.
Oh, me too. Definitely.
Yeah.
Definitely. And I think you have to tell me, you know, when you read the book, what you think.
I will. I would
Okay.
love to do that.
I would
And
love that.
thank you again so much for your time. I would like for you to share with my viewers how they can reach out to you if they need your help.
Absolutely. So I think the easiest way is, if you're on Instagram, is to follow me on Instagram, because I do try to put out a lot of content there. And it's Dr. Serena H. Chen. So it's Dr. Serena, like Serena Williams, H as in high maintenance, Chen. C-H-E-N.
I will have everything in the show notes so people can find you easily.
And then, of course, you know, I'm on Twitter, I'm on LinkedIn, and then drserenahchen.com. You can use that too. So lots of ways to find me.
All right. Well, thank you so much again, and I would love to do this again sometime.
I would love that. Maybe we can talk about happiness advantage or big potential.
Yes, I would absolutely do that.
Okay, cool.